post-elimination. Definitely the equipments are provided for TT surgeries for the next 2 to 3 years. The domestic resource mobilization, we, together with partners, we developed a tool for enhancing resource mobilization and allocation at subnational level. This was, I think, 2023. And I can say that our districts, we have the districts I showed you in the, on the map, about 5 districts that were recrudescent or persistent, active trachoma. And these districts have gone ahead to allocate monies, whether it's for supervision, whether, and we hope that this will actually be in a more incremental fashion over the years. But also at the national level, with the recent budget review, I think last month, we still fell under the unfunded priorities, NTD intervention. So we still continue to, to request for more money. And so far, the indications they may get us, just the bare minimum. So we, as Uganda, having this at both the national and the subnational level. Yeah, so this is next slide. So this year we plan to have 17 transition planning meetings because, as I said, ours is at a lower level. So the numbers shouldn't, worry us so much. I think we've done already about 2, 3, 4, and we'll have to do much more. Next slide. So what remains? We remain with balance of surgeries and finishing the balance of TT case management, continuing the F&E, and making sure our dossier is well patched up, ready for submission, hopefully by 2027 or 2028, but we do not want to reach 2030 when we are still not sure. So that's really what remains, what you see on that slide. Thank you so much. Next.
So thank you so much, Dr. Raphael. I knew you were to come twice. So you will be the next one in session moderating. But before you prepare, I know maybe participants are also having sets of questions. Looking at the program, we also have the plenary session where we can make use of it. We didn't have a parking lot, but somebody was asking, Daktari, while you are here, whether your phone is, which net is it connected, whether it is Safaricom or Airtel. Now, because of that kind of questions, allow me to push the question out to the plenary session. So somebody is wondering whether you are in Safaricom or Airtel. In other words, I'm giving you time so that you can be ready for the mic. But you can appreciate him better. It was a good experience. Yes, thank you. I've seen a number of you taking notes. Not so sure whether it was you are maybe capturing the experience or because there was some forms going around. So not so sure, but people are very serious taking notes. So now let me hand over the mic to the next moderator, who is Dr. Raphael.
Where I come from, when we hand over power and the microphone, we clap because it's not easy to hand over power. So feel free to appreciate him. Thank you so much, sir, for taking us through your session. And so this is a good sign that what you see, you know how he demonstrated the handing over of the microphone. We shall carry the lessons home, okay, as we go back, so that everything goes on well. So I would like to invite, in no particular order, the participants for the panel discussion. One, which are basically the key highlights of the transition plans. We'll be looking at some opportunities and gaps. So we would like to request the participant from Chitui County. Hope if I don't pronounce well, you'll forgive me from my accent. I think my accent is should be around Kisumu area. not so forgive my accent. Those are our young people. When we stopped in Uganda, as we were migrating along the Nile, they decided to continue migrating further. So they ended up in Kisumu. Yeah, so let's have Kitui County, Embu, West Pokot, Turkana, and Baringo County representatives to take their seats. I am not so sure of who they are. Do they know themselves, or I handpick? I'd be happy to handpick. Yes, I see Samson is warming up. Samson, you're welcome. And I think Samson is for Turkana County. Okay, great. Yeah, so feel free to have your seats. Join me. So let's clap for them, because sometimes, including, we may need encouragement to come up here and face you. So we're going to get into a very interesting session. And just a second. So great. Do we have enough microphones? Probably more 2 microphones. Great. So in this session, or for this panel discussion, we shall be okay, I think. Okay, thank you for that support. And I think my first question is going to go to the representative from Embu. And the last World NTD Day that we had in Uganda, our commemoration was actually after the US work stop order. So we had to think outside the box and try to look for collaborations. And interestingly, one of the partners that we collaborated with was the Scouts and Girl Guides Association of Uganda for NTD commemoration. Something which we had not done before, but with what was happening, it was one of the, the things we decided. And I can say we had a very successful commemoration, and we had a very wide reach. So to my colleague from Embu, my question is, which untapped opportunities exist for collaboration with WASH, education, and other sectors to strengthen your transition plan? Let me just repeat, which untapped opportunities exist for collaboration with WASH, education, or other sectors to strengthen your plan?
Okay, thank you very much. Good afternoon. I am Paul Ngari, Director of Public Health, Embu County. With your permission, allow me to bring the members into perspective about Embu. Embu, we began the implementation of trachoma, triachiasis, 2012. That is when the journey began. And the survey that was done then, it indicated that we had 0.6% of TT cases. Of course, it was higher above the WHO 0.2%. And then we began the journey of MDA and other interventions, which the year 2018, and then come 2019, we did some verification, which we later came to realize we had a backlog of about 512 TT cases that we needed to work on. And therefore, in regard to the question which has been put to me and to Embu at lunch, on the opportunities existing in regard to the WASH education, among others, collaboration, is that we have realized the need to have one health approach as one of the key area of multi-sectoral collaboration in matters to do with the Trachoma approach. And what we are doing, especially in the Department of Water, unfortunately I can't see my colleague, Gatuta engineer, and I'm not sure whether he came. What we are doing is that we are empowering the community, because in Embu we have unique climatic zone, highland and lowland, dry, actually arid and semi-arid, because these TT are actually burdening two sub-counties, that is Mbere North and Mbere South. And so the two sub-counties, they are arid. So what we are doing with the Department of Water and Irrigation is to ensure that the communities are enjoying the benefit of having the boreholes, which are done by the Department of Water and Irrigation. And that is going a long way to ensure, especially the component of F&D, is well taken care of. Then there is another policy we are leveraging on, and this is the school health policy. The school health policy is so rich to us who have a private to the school health policy. And what we are doing is to make sure that we are able to implement most of the policy guidelines that have been premised in the school health, particularly on the issues of WASH, where we have been able to form even the school clubs, the school health clubs, the training of the patron, and ensuring that the component of the FRD and also the environmental improvement has been taken care of. So over and above, basically that is what Embu is doing, and we feel we are doing pretty well as we endeavor to more progression and improvement. Thank you.
Yes, thank you so much. It's especially exciting to hear about the school innovations from the school health policy, and we wait to see what comes out of the implementation. And next we shall be moving to our colleague from Kitui County, and we want to ask about, to give us, two strengths or innovations that we can pick out from your county's transition plan. What are the two things, the two strengths that you can clearly, spell out of your transition plan?
Okay, thank you so much. My name is Faith Mutinda, Deputy Director, Public Health, Kitui County. And I'm very much delighted today to be in this panel to discuss about the strengths, especially from our Kitui County. And first of all, I want to say that I'm happy that today I come with a team of stakeholders who are really helping us in actualizing our dreams in matters elimination of trachoma. We have the Director Water from Kitui. We also have Director from Education, which is a plus to us. But I want to say that one of the biggest strengths that we are experiencing in Kitui is the political goodwill. Our governor is very much concerned about water provision, as we know that we cannot eliminate trachoma when we have water challenges. And in our governor's manifesto, which we call the Kitui Promise, we talk about access to water by the residents of Kitui County, and also in our county budget for health, we could see a drastic change in increasing budgetary allocation to preventive promotive health. Unlike what used to happen on allocating much money on curative services. So that is one of our strengths that we are banking on. When we started doing the transition planning, we had to do our mapping of our partners whom we work with. That is the line ministries within the county, also the national government, and also the partners who are working with us on the ground, so that at least we know, because for us to eliminate, we have to work together. As a county, we have been working closely with in our transition plan, you could see that we have allocated roles for each and every stakeholder, including our community health promoters, who are the key people, who are the first they are the first people to have contact with the patients or the clients at the households. So in our county, we are really privileged to have 2,470 community health promoters who are really supporting us in identifying the cases in the households. So that is one of our strengths, because they are giving us the reports from the households. And then now we have our stakeholders who also support us, that is our line ministries, whom we are working closely with them, and also I would say that the political goodwill is a big plus to our county. So I think that is what I can say. On the transition plan, again, I would say that we shared this transition plan with our seniors, that is the chief officer and the minister, and we have, when we are developing our county health strategic plan 2023-2027, we ensure that eye care, primary eye care, we are not only looking at trachoma elimination, but we are looking at eye care as a whole, because there are also other eye conditions. So in our strategic plan, we have eye care captured very well, and also when we are doing budgetary allocation, it is well, we are doing allocation of funds to ensure that primary eye care is also taken into consideration. So at this time, we are now doing our annual work plans, and it is something that we are ensuring that we give eye care, primary eye care, a nod in our annual work plan, so that it is not left behind. And also there's a budgetary allocation towards primary eye care. Not looking at, per se on trachoma elimination, but we are looking at the general primary eye care interventions. Thank you.
Thank you so much. Lots of good responses there. The political will, issues around budgets, and also issues about, involvement of all the community, extension workers. And to the colleague from West Pokot, what critical gaps, or could I say risks, remain in your transition plan that you think require urgent attention? What are the risks that you identify in the transition plan? Because we mentioned that elimination of trachoma is potentially reversible, because the professor went at great lengths to give us the 3 criteria that WHO looks at, and the last criteria he spoke about was evidence that the health system is able to, manage the cases that come, after we've celebrated with you as, as a county, but also as Kenya, that you've eliminated trachoma. So what gaps or critical gaps or risks do you see in your transition plan?
Thank you so much. As I've said, I'm Ben Soruta Chumagemera, Director Public Health, West Pokot County. For the gaps that we have to experience in West Pokot County is that we have several gaps that actually are most likely to cause to refer back to the same situation that were before. One of it is that in those areas we have an accessibility to some parts of the county. We have the accessibility, road network is very poor, that we cannot be able to access. to those some areas. Some parts are accessible, but most parts are not accessible because of poor road network. Another one is that the gaps that we see that is really affecting our county is about insecurity. Actually, we move along the borders, especially between Pokot and Turkana. We have an issue with insecurity. That's very hard to reach to the population that is in those hard to reach areas or insecure areas. Another one is about, we have the CHPs or community health promoters in place, but we can say that they don't have the adequate knowledge in actually the implementation of the wash activities in those areas. And then we have also issue of network problems in the communication and coordination in that area. Those areas, sometimes we have some areas that does not have any network, or if there's no network, so people find it hard for communication. So it's not easy to do some communication in those areas. Another thing is that we have to face as a challenge is about language barrier. Sometimes a language is an issue when we move along the border, or those people who have been employed, healthcare workers who are employed in the area, sometimes they don't understand the language of the community. So there's an issue of language barrier in those areas. And then inaccessibility to availability of water. Water is a challenge in the area. There's no adequate water, or if there's water, then the water may not be clean, that can be used for consumption and use of other types of activities at homes. We have also the issue of nomadism. The nomadism is another issue, very big, whereby the community, you can find it today, they are around here. The next, after 1 month, you might end up not getting them there. They have moved to another places. So those are the few things that actually is a challenge or a gap in our county. Thank you so much.
Yes, thank you so much, and thank you for your, for your very big input there. I want to move to our colleague from Baringo, and I want to ask one question, and I just want to know what strategies you propose to secure county-level budget support for your transition plan.
Thank you, our moderator, for the question. And for Baringo, I think it's one of the very vast county, and also we normally call it a county of great diversity. And it is very diverse in so many aspects, maybe the population, the terrain, and all that. So issues of budgetary issues and resources are always limited. It's never adequate, especially if we compare with the vastness of the region and the terrain. However, the county Department of Health has done a lot. They have factored in the issues of commodities and supplies in their budget. And most commodities come through KEMSA supplies with the support of the county department budget. We also do a lot of lobbying through the county assembly budget committee for increased allocation, so that we have more funds for health. Otherwise, I think those are the few challenges. I mean, those are the few strategies that we have, and also working with other multi-sectoral collaborators, other friends that support health services. Thank you.
Thank you so much. It's great to hear all those strategies that you've lined up to see how you'll be able to actualize the county level budget support. So, dear colleagues, we will take one, question here for Turkana County. Then we'll give opportunity to us in the audience to have at least a question could be from what, they've already shared or what they had to share. So probably you can write that one single question that you need at least one of them. If you are able to point to the person that you need to respond to your question, that will also be very good. So, Samson, I know we've been in the bushes with you, very deep, far in Karamoja. And for me, my question to you is, how will your county embed trachoma surveillance? You're very well aware that the population that you deal with and that I also deal with are sometimes want to term as mobile and migrant populations. And soon, I was speaking to Titus, maybe tomorrow we'll hear that Loima has passed the surveillance survey. So we'll know that you don't expect but anymore, you probably will not have any more MDAs there. But what, in terms of surveillance, do you have in plan? Thank you.
Thank you, Raphael. The disease is there or not. One of the things that we have done is to train our health workers to be vigilant, to be able to identify these cases and report to us. The health workers, the community health promoters, the community resource persons, the crowd leaders have been trained specifically on trachoma since we began. That if you see a person with a red eye, discharge, something, kindly refer to the health system, and the health system will see what to do. And due to the safe strategy, and due to the baseline survey that we did, could tell us whether we have improved or not. Remember, Turkana was the one which had the highest prevalence of trachoma in Kenya, with 42.3%. I have heard from Baringo there were 34, so that was not much. And of course, with all the factors that predisposes us to trachoma. For example, flies. Another white man was telling us, he never believed he could go a place where he can see 1,000 flies. I don't know how did he counted the 1,000 flies. But they are all issues of predisposition to trachoma, where open defecation is still very high. It was still suspicious that trachoma could still be there. Water lack. As you know, Turkana is dry. And of course, their way of life exposes us to trachoma. So when we were told we were the highest, with the highest prevalence, you are not worried because all the predisposing factors were showing that. So surveillance is a continuous process. We use our health workers, we use our community promoters, and also we do the surveys, the baseline surveys, and later on we did the impact surveys. We also try to include in our surveillance system, although it's not an identifiable disease. So we used to say, if you see this case anywhere, just report us any other, and then right there and say it's an eye disease. I saw an eye problem, and that makes us to investigate further. What could it have been? So surveillance is key, and as per now is all our evaluation units, where most of them went to surveillance, and now we are doing Loima, which is, we are doing surveillance survey now, except Turkana West, which has not done the 2 MDS, and therefore we don't know. So even me, I don't know what Loima will tell us. And of course, with recurrences, recurrences that we have not sometimes again, still are. And we have also asked the health workers, any suspicious case, to be reported to the health system, and the health system can follow it up. Of course, cross-border, I know I have moved with you looking for, you come to Kenya looking for Karamoja, but I also go to Uganda to look for Turkana. And you realize that when you are there, the Turkanas told you, your drugs, no, until the drugs come from Turkana. But due to our collaboration, and you are reporting that, oh, locally, we have 10,000 Turkanas in Uganda. Come and deal with them. That is also part of surveillance, getting us information that there's this number of people existing in that area. And that makes us to react. Our county government has been doing cross-border efforts. Of course, One Health. Of course, our CRA leaders report to us what happens in their respective CRAs. If it is an outbreak of an animal disease, if it is an outbreak of a human disease, when they report, we go there and investigate further and help them to manage the cases. So our structures through community health strategy, our structures through community health strategy, our structures through the One Health program, our structures through the health system. Unfortunately, Trachoma is where the road ends. When the road ends, that's where Trachoma begins. And unfortunately, people don't like where the road has ended. But we commit ourselves to ensure that no one is needlessly blind due to trachoma, for it is just a preventable disease. Just provide water. Through that, we used to have task forces, the trachoma task forces, and we used to have also West Coast teams that were vigilant on any case, and that if it is reported, it is done. We also use supportive supervision. In the process of supportive supervision, we are able to report any case that is reported, and that makes us to be able to deal with any case that is reported. Otherwise, surveillance is key, surveillance is continuous. Even after transitioning, surveillance will continue because we will always get a case thereafter, and that cases can still be managed by the health system. Thank you.
Yes, thank you so much. Can we give them a hand clap? I need to at least take one question from the audience. I don't know if we have someone who has a ready question. Gilbert, I know you may have one. So let me skip you for now. Any question to any of them? Just one? Or there's one. Yes, thank you.
So thank you. My name is Martin from Embu, and I'm concerned about West Pokot. I had something to do with mobile network challenge. And I think I want to assure our very good director that soon things will be good, because through the rollout of the national HMIS system, Safaricom will make sure that network is there, the farthest facility, like it's happening in Embu. Thank you.
Thank you. He's given assurance to one of our colleagues who was worried about network challenges.
First, I want to thank everybody there. They have really raised pertinent issues. My concern also goes to West Pokot, and especially pertaining to the gaps that have been mentioned. You know, from the one start, people were saying that they have a lot of goodwill, political goodwill. And I realized the director was saying some places are not accessible. And I remember those days when they are doing intervention there by L Mission, they are using helicopters. And now, even now, a lot of helicopters are roaming in West Pokot. I don't know whether you can just have that goodwill of political will to have some things, like maybe helicopter to do some, to reach places. Another one is maybe he was talking of availability of water. Water is not available. And you realize that the county has a lot of risks, that the political will is really maximized, they will maybe make a lot of changes pertaining to water. Also, use of CHPs. CHPs are available. Once you really struggle to get to those, when they are well trained, they will be able to cope and make changes. Mapping of hotspots so that you, maybe mapping of the hotspots can also make your work easy. And this is applicable to everybody. Thank you very much.
Thank you. The colleague from West Pokot, I don't know, you need to speak about helicopters and the likes of it. So you need to prepare an appropriate response. Gilbert?
Thank you very much, Dr. Pon. I actually like the questions that are being posed just now, because I think they come from the heart and they are genuine concern. I just want to add to them by saying that even at the WHO level, there has been a lack of clarity on what post-validation surveillance would look like, mainly because the circumstances are unique. So there are various surveillance methods, from the HMIs to sentinel sites to doing rapid assessments at a certain period. I just wanted to ask one of the panelists to volunteer to give us a picture of what would be most effective in your context. Thank you.
Thank you. We are getting, because the responses will also take some time. The questions are pregnant questions. So, James Peter, I probably will first allow our colleagues here to answer. And I think our colleague from West Pokot, you got the question. You'll need to go in first, then I'll need a volunteer to answer the second question. Can you tell us one, just in the simplest form, what does your post-validation surveillance look like? Okay? If you are to make 4 lines, 1 is this, 2 is this, 3 is this. So let's have the colleague from our panelists from West Pokot go first. Then we'll have anyone who is ready to answer the second question. And thank you for some of the feedback were re-emphasizing some of the responses that our panelists have given. So thank you so much, West Pokot. The floor is all yours.
Thank you very much. Maybe I would like to ask to answer that question about accessibility. As I mentioned, that some areas of West Pokot is not accessible now. In fact, even it is not accessible. And you have talked of the helicopters. Actually, helicopter is not sustainable. You cannot have an helicopter. Do we have any county in this country that have an helicopters that are using for such a work? We don't have. So we need to have a road networks. But that's the issue up to now, because we have some areas which is unreachable or hard to reach areas. I'm sure that you come from that county, also you have been working in that county, and you know that those helicopters that you hear about is for the politicians moving up and down. It is not for the Minister of Health. Thank you so much.
Thank you so much for your response. Do we have any volunteer? For the yes, sir.
I don't think I have clear answer equally to how the post-validation would really look like, particularly in the case of Embu, where I indeed mentioned that we have about 512 cases of TT in terms of backlog. But I want to imagine the interventions that we have been doing, much as they may look more in terms of EBACT, there is a significant improvement in regard to especially the active case search and bringing back to the treatment. And leveraging on the architecture of community health promoters, for me, I think that is an investment that has worked wonders. And I want to believe the efforts that we have been able to do, if we were to do post-validation, I am persuaded in my heart we are likely to see a different scenario. But sorry? Am I audible? But that does not mean we would really say that we are out of the hook. So it's an anxious moment, but do we have a choice? I think the best thing is we do it so that we see the larger picture of how it would look like. Yeah.
Thank you so much. Yes, one more in about 2 to 3 minutes. That's we.
Okay, thank you. I think when we are talking about surveillance, I think we need to be guided by data from the KHIS, because the data will inform us on the prevalence and the trends. So I think when you are doing surveillance, we need to really focus on data from KHIS. And also again, as my colleague from Embassy just said, we need to do like periodic surveys to map out through the CHPs, and also getting reports by what we call active case search, so that at least we'll be able to know what is happening in the county. Are we having new cases? Are we having people? Are the interventions working? So I think we need to be guided by data from KHIS and any other source of data, so that at least we have a mechanism of following up the issue, the whole issue. Thank you.
Yeah, to add on that, we also what we've called community census. And of course, we have hotspots. We already identified some hotspots where we are suspicious that even if we have done well in these other areas, these hotspots still expose us, especially in hard-to-reach areas, in migratory areas, in cross-border areas. If not well attended, we are always suspicious that cases could be in those areas.
Okay. So thank you so much, and thank you, dear panelists, for your responses. I know this is an ongoing conversation. We should still be able to have more sessions tomorrow where we'll refine some of these questions, and probably by the time we leave, we, apart from just, having the transition plans out and running, we shall also be giving a lot of thought to what does post-validation surveillance look like. Again, you don't need to feel on the wall. It's the same thing back home in Uganda. We're trying to think through as widely as possible. For example, we are asking ourselves, do we integrate surveillance, especially if you have trachoma, you have another NTD, do you leverage on other routine eye disease assessments in the county that you ride and have something small that you could be able to pick a signal of whether trachoma resurgence. So those are some of the the little things. We know that post-validation, the resources that are dedicated usually dwindle, but you also don't want to miss any signals that you need to respond to. So thank you so much. It's been a pleasure having them, and let's clap for them. Great. My tenure on this podium has been rather short, so I don't want to continue beyond now. And yes, I don't need another term. Gilbert is already trying to compromise my position by telling me to request the House for another term, but I'm going to behave, Gilbert. I'm going to behave and make sure I don't amend, okay? I don't need to amend this agenda. So we'll invite the next session lead, our colleague from Kemri, Dr. Paul Gichuki. You're very welcome, Dr. Paul. Okay.
Thank you very much. Good evening. Power is transitioning every 2 minutes in this room. So we are going to have, I think, the last session of the day. And this session, we are going to have it with the chief officers from the 5 counties. So I want to take this opportunity to welcome the chief officers. Karibuni. And the conversation that you are going to have with the chief officers is around resource allocation and financing for sustainable elimination, and how counties can be self-reliant. So thank you. We are missing one person from, I don't know which county. Embu. We have Turkana, we have Baringo, West Pokot. So we are missing Kitui. Do we have a representative from Kitui? Okay, then guess we can still have this conversation with the 4 counties. And as I said, we are looking at issues of financing, how counties can continue financing post-elimination. And my first question will go to Embu. How can counties institutionalize dedicated budgets for post-elimination surveillances?
So thank you. Riding on all the protocols, good afternoon. My name is Dika Henry, Chief Officer of Public Health, Embu County. We normally have the CIDP, which is takes 5 years. And during the planning period, that is during the CIDP, that is the best time to make sure that you plan for budget as far as the high health is concerned. Actually, in Embu, in the current CIDP, we had 10 million. We have 10 million in the CIDP for eye care. And we are very keen also to make sure that during this coming budget, we put some money for the eye health.
Thank you. And then we are going to hear from West Pokot. How can resource allocation be optimized by integrating Trachoma post-elimination to the other programs health programs that are being run in the county? For example, WASH.
All right. My name is Dr. Kokwo from West Pokot. standing in for the Chief Officer for Health. So I think the question was, if I got it right, how can resource allocation be optimized by integrating Trachoma efforts for, with the WASH and education and so on, right? All right, fine. I think my response to that would be to combine the joint planning of these activities together with, you know, like when you're doing the planning for WASH, education, and primary healthcare, we should do joint plans. And in that case, we are saying that during the planning cycles, we ought to be able to really do this joint conference planning so that all the sectors are involved, those from the education sector, those from health, those from WASH, just a similar setup like what we're having today, so that we can all pull our minds together and be able to come up with interventions that are interlinked. Yeah.
Thank you. Thank you very much. And Turkana, how can the counties ensure equitable resource allocation, especially for populations that are highly at risk populations?
Thank you. How can the counties realize the equitable allocation of resources? In this is whereby the county assembly, which is the one which allocates this money to the departments, we can always justify the allocations of this money to the department so that our people can realize this allocation, whereby if we justify our priorities in the county assembly or in the health committee in the county assembly, the money will also be wired to the respective departments, so that for the implementation of the interventions that we need or we have for our local people, and also reaching out to other partners which can also help in scaling down the issues of this pandemic in the community.
Thank you very much. Baringo, how can counties invest in community-led monitoring so as to maintain trachoma elimination? Repeat, thank you. So I'm asking, how can counties invest in community-led monitoring so as to maintain elimination of this disease?
So thank you. So my name is Nancy Chesire. I am the Chief Officer, Medical Health and Services, Baringo County. Sitting in for the Chief Officer, Public Health, who has just stepped out. Now, just the way we have done, we have come in together from different counties so that we bring our minds together on how different communities have been handling their cases of eliminating these trichomoniasis in our counties. Now, when you say how we can come together, one, we've done it today. And when we come, we share different ways. Now, we have people with different, coming from different geographical conditions. We have different cultures, and we have different ways of handling or trying to come around these cultures. So coming together and at least ensuring that, we have our money channeled to the right places, Like now, for example, we can assist, bring down these percentages by getting our money through education, ensuring that our children, learn how to wash their hands after coming from the toilets, and also ensuring that, we have water in all the facilities, the dispensaries, and the hospitals. No, dispensaries, and also schools. Yes.
Thank you very much. And those are very good insights. Embu, I know we get a lot of data, health data, we every day in the counties. What do you think, how can counties use this data to justify resource allocation post-elimination of diseases?
So thank you. The data we normally get is very important because we can use it for purposes of planning. Yes.
Thank you. And I think that goes with what Chief Officer of Turkana said, that we can use this data to justify and also, do more advocacy to the county assemblies to be able to allocate more money or resources to this process. So we are going to have a final question to Elgeyo Marakwet, and this is what innovative financing could sustain disease elimination in the counties? Yeah. Sorry, West Pokot, not Elgeyo Marakwet, West Pokot. Sorry.
Okay, thank you for that. Fine. So what innovative financing that we could use to sustain elimination, right? Yeah. So looking at that, I think we can try to engage through the PPPs forum, like with telecoms, through SMS, awareness for, messaging. Safaricom, sometimes if you are able to talk nicely with them, they can be able to come up with these pop-up SMSs to help us to, go around this. It's really a very wide area, and I don't really have a very clear answer to it, but I think if we try to use the telecoms, the SMS platform for messaging, it can help.
Thank you very much. Allow me to open this to anyone who might have a question to the members here.
Thank you. Mine is not a question. My name is Kosgei Kipruto. I'm in education. And I just want to give a suggestion. And this is something that I've seen work in Embu. I'm from Embu. And in our schools, we have health clubs. And this is very common in our primary schools. So these health clubs, we normally have any intervention that we want to deploy in the school, we normally penetrate using the health clubs. And in this, I want to believe we can leverage on the health clubs in schools, probably to encourage good practices, good hygiene practices, very basic. Like I remember during the COVID period, it is through this that we emphasized hand washing. And children tend to have high adherence levels, unlike adults. Like if you tell children don't do this before this, the protocol is maintained. And I'm trying to imagine in areas where we have prevalence of Trachoma, we can ensure that we have targeted approaches to sustain the training of the learners around those areas. I saw Colgate Palmolive. They came to Embu in 2023, and they were promoting issues of oral health. And when they went to the schools and they were encouraging the learners, they were actually even almost having competitions where the learner who practices how they are taught is given a small token. You know, for children, even if you give, for example, this sweet, they really get encouraged. So as basic as that, if there are some elements of interventions that we can deploy through Ministry of Education and through our schools, using cascade model where you just train some few teachers, and the teachers train the learners, of course supported even by the CHPs, I want to believe we will be moving in the right direction. Secondly, I'm also trying to look at local radio stations. Here in Kenya, and I've seen, like in Embu, we have around, I think, 3. Dr. Ngari? I think we have around three local radio stations. And therefore, if we tap into that, and you know, it may not have a cost because they have a CSR. The radio stations have a CSR. So it is just scheduling with them, and then you have a session with them, you talk to them on the best practices. And even the local radios, I mean the TV stations. So I want to believe these are interventions that may not require a lot of money, but they, in the long run, become sustainability opportunities that we can explore. Thank you.
Thank you very much. I'm coming to you.
Thank you very much for this opportunity. Mine is a general comment, not for specific county, but to echo the role of health financing. Because there's a document, it talks about the 6 pillars of health system strengthening. And among it is health financing. So it makes finance managers are very key in this journey. So budget allocation is very crucial. And since this is a neglected tropical disease, it can also very easily be neglected if we don't own it up at the lower level or at the county level. So issues of budgeting and financing are very key, and we expect quite some good money to be set aside in this work on all the entities in our area. Thank you.
Thank you very much.
Thank you very much. Mine is about, there's this fund called Equalization Fund. I was seeing the counties who are here, most of them are from ASAL counties. So I don't know, as chief officers, is there anything that you have planned to see that maybe this money, when it comes to your counties, one of the top priorities is to invest to this transition plan that we have today?
Thank you. Will anyone comment about the equalization fund? Thank you. Baringo.
Okay, equalization fund, when they assign to the counties, this money is normally planned. and allocated to various departments. So it is up to now the department to ensure that they give their priorities, so that when they are allocating money to the department, then you will have given out your priority in budgeting, that I will need this money for such and such activity. And so you divide the money that has been allocated to your department, and ensuring that some part of the money is actually given towards prevention or promoting this condition. Yes.
Thank you very much. Prioritization. My brother here had something to say.
Thank you to the panelists. I was curious about which aspects of the SAFE strategy you have been most involved in, and which one have you been least involved in? I guess one person could answer or two. And finally, the same question, which one would you look forward to being more involved in? Thank you.
So the SAFE strategy, where have you been more involved in? Maybe we can have Embu.
So thank you. I would say that in Embu we have what we are calling the FIF, that is the Facility Improvement Fund, which came into place June last year, where all the revenue are collected from health remains in health. That is, it is reinvested. So that means that we have an opportunity to prioritize the eye health. And like I said in the beginning, we have in our CIDP, it is there. That is, we have some money for the eye health, and also in our next annual development plan next year, we have also put some money for the same. Yes.
Thank you, Ebu. Turkana.
In Turkana County, there is a component of WASH, which has also been prioritized by integrated departments like the water department and health department, whereby we have already allocated some funds for these components. Like in health, we have already allocated 10 million for WASH components. And also we have another program called K-WASH, where the two departments have already been integrated. And water department has also allocated some funds where we do integrated activities to make sure that even this also stretches into our schools and even the community, to make sure that WASH activities are implemented in the entire county, as well as the ODF, because Turkana County is one of the high-burdened counties in the ODF, and we wanted to eliminate also the ODF in the county, and that is why we have prioritized the WASH components, which also translates to elimination of trachoma, because WASH activities or lack of hygiene and sanitation translates to the trachoma upsurge in the counties. Thank you.
Thank you very much. Did we have any other hand?
I think I've always heard people talk about eliminating ODF. We do not eliminate ODF. What we do, we eliminate open defecation, OD, so that we achieve ODF status. And it is important that, because when the governor was also talking, I think he also talked of the same. We need to be very much well advised. Otherwise, we'll be saying that we'll be, when we are eliminating ODF, it's like now we are going to OD. So use the correct terms. Thank you.
Thank you for that. Oh, Jane.
It's just a concern, and maybe how we need to get some clarification from whoever may have much knowledge on the equalization fund. Equalization fund goes to counties that are marginalized and even to sub-counties, specific sub-counties. At the sub-county level, they go to wards or locations, again marginalized, considering marginalization in those sub-counties that are marginalized. So this money is being done public participation. So the needs, each location is allocated sub-amount from the budget. So the public do public participation according to their priority needs. So the needs and proposals come from the community to the sub-county, where the heads of department will sit and discuss and see the proposals from the locations. You just pass those proposals the way they are. We don't interfere. I'm one of the committee at the sub-county level as head of department for health. Now it goes to the county. At the county level, and then it is now the specific departments. There are around 5 departments. Health is there, education, infrastructure, and then we have water, and then electricity. There are 5. So I don't know how the issue of trachoma, how we are going to maybe, have some adjustment to handle trachoma. Maybe now having water is a way of prevention and other things, but asking the chiefs or whoever, I don't think there's a way they can do some manipulation. Thank you. Yeah, it is a prevention. Yeah, but they don't have anything to make some adjustments. Proposals come from the community the way they are, passes through the sub-county HODs to the county. Yes.
So maybe still just a clarification on the same. When you are saying that issues come from the community, those priorities, who in the community, do we have, community champions?
We have, of course, the leaders from the community level. We have the chiefs, the sub-chiefs, the COPS people, those are the community-owned resource persons, representatives also from women, people with disability. So they come at a location level, then they discuss. Yes.
Thank you.
Thank you very much, moderator. I would like to thank the panelists for the submissions you've made. Mine is to pick some experience from your counties. Following from the MOH presentation, how the transition plans were developed, reviewed over and over by counties until they were good, and all the counties were happy with them. I wanted to find out, or rather borrow some experience, because what I've heard from the panelists is synonymous with what happens to us also in Uganda. That some of the decisions lie or arise because of people who have goodwill. Maybe you have a good political will you have a health officer who has a goodwill towards the eye health, and they're able to advocate for funds to be put in the annual plan. So it happens with us also in Uganda in some districts. So, but you know, today you have a leader with a good will, tomorrow you have another person with a biased will or a bad will somewhere. So I wanted to know whether the gap of funding, sustaining the domestic funding or county funding towards eye health was taken care of in the transition plans. As in, have there been some lines in the plan that commit counties to allocate a particular percentage of funds towards eye health when they're doing their budgeting, so that even when people change tomorrow, the same document can be used, can be referred to ensure that there is sustainable financing of eye care activities in the district. I wanted to pick some minds from you so that maybe we can also learn, because for us, it is back to goodwill, which I've also heard from you. Thank you.
Thank you very much. Maybe Embu.
So thank you. In Embu, we are in the process of developing a eye health policy. Of course, this will guide the funding and all that. We shall also be using it as a tool for mobilizing resources. And once a policy is in place, when it comes to funding, I believe that it will give the guideline. So it will not depend on maybe the political goodwill or whatever it is. So the issue of the policy is very, very important. It is very key to give the guidance.
Thank you so much to the panel, and I'm very glad when the chief officers are now speaking about sustainability and resource allocation. I would, however, like to make a request. Most of these healthcare interventions are much more vivid when you participate directly. One of you talked about participation in WASH. I was very happy that covers F and E. I was asking Titus here whether he can organize the next surgery. The chief officers will come and take a look. I don't know if you've been involved in the surgeries, but if not, I wonder if you're curious to come and see what the surgeries look like. Today there was this lady who was giving testimony, but in your own location that you're responsible for. I just wanted to appeal and say, if you're willing to witness the surgeries, we'll dress you up during the next surgeries and you see how we handle your people so that you relate to, again, the S component. Is that something we can take up? Okay.
Can I say something about
Let's go ahead.
All right.
Thank you.
Thank you, Dr. I think when you asked which of the safe strategy that we would probably pick on, for West Pokot, I think in the morning the Director of Water was here, and you saw how he was passionate about the boreholes that are being drilled and all the water strategies that are out there in the community. I think we have very good political goodwill on that line, and we will write more on the FE component, right? That's more of preventive for us. But of course, we know that for the S and the S strategy, for S, we're glad that Fredol was really helped us way back by training the surgeons and pre-positioning personnel. So all we need to do is just support them to be able to carry out the activities. And of course, we'll be glad, the chiefs will be glad to have a look at the surgeries happening. And I think that will help us to also put focus on risk allocation. Yeah, basically that, yeah.
I'd like also to give a comment on what my brother has just said on seeing or witnessing one of the surgeries. And I'm privileged to be here and to say that last week I was privileged to witness one of the surgeries that were done by our surgeons in Turkana East, where we had a high prevalence of the trachoma. And that also enabled me to make sure that in the next budget we will make priorities, or we will prioritize the eye care interventions or allocation, because most of our people suffer from it, and we would like it to be one of our success stories that we have, and putting more money in it shows a seriousness in elimination of trachoma in Turkana County. Thank you.
So thank you very much, chiefs officers. Just before we close, I think there is something that has been on my mind, because when Titus was presenting, I know we've been knowing that we have 12 counties that were endemic for trachoma, but he mentioned that now we have another one, Elgeyo Marakwet. It was in my mind. And I wanted to ask, I don't know whether, Prof, you have any information, what plans are there for Elgeyo Marakwet now that it has also been found to be endemic for trachoma? Okay. And thank you.
Thank you for asking. In the temporary absence of Titus, who is my boss, so I'll try to answer. So for Elgeyo Marakwet, when the survey was done last year, but one, we found the active form of trachoma was below prevalence, not requiring any intervention. So the problem for Elgeyo Marakwet was TT. And we have gone in to support with the management of the TT cases through what we call the documented full geographic coverage process as recommended by WHO, because they do not have any other survey that will be coming. So this will be evidence enough for the elimination process for Elgeyo Marakwet.
Asante sana. So I'll take this opportunity to really appreciate chiefs for the insight that you've given us. And I would want to ask Ruth to kindly come and appreciate us in the fashion that you know. I know she's very good in this.
Thank you, Dr. Paul. My name is Ruth Monene, County, and with all the praises, cannot afford to do it otherwise. Paul, I think you're also part of the team to be appreciated. Yeah, kindly come this way. Thank you, Chief Officers, for job well done, and so we want to appreciate you. I'll kindly ask you to stand. And as they walk to their seats, we shall be doing the Obama clap. You know the Obama clap? Non-stop until they go to their seats. So we need that as they walk to their seats. And they walk waiting to the
I didn't know that is the Obama club. But now looking back at the US elections when Obama was running for the presidency, it now resonates. It comes home. It's been a long day. And I'm sure the energy levels have gone down. We've had very, very good discussions from since morning. And we'd like to call it a day. And before we call it a day, we have some goodies for you people. So we'll place a box here with some goodies. You pick one as we go out. There are 2 items. You pick one each as we go out so that all of us can get the goodies. I think this marks the end of day 1 today. We still have a day tomorrow to go through the panel discussions, and then of course wind up the day by validating the transition plans. Yeah? You want to give them out? I want to place it here. Just walk in and place a good, pick a goodie for you. And on that note, may I invite a volunteer to close the day with a word of prayer? Who wants to close the day with a word of prayer? Who has been touched?
Can we all rise for a word of prayer? Praying. Let's close our eyes. Our Heavenly Father in heaven, we come before you with thanksgiving in our hearts. Indeed, we asked you for your presence as we began this workshop, and indeed you have been with us. As we head out to our various places of stay, we pray that may you guide us, may you protect us, and may you bring us back safely tomorrow to continue with the deliberations. In Jesus' name I pray.